Good morning, and welcome to Second Opinion. Urologic Oncology investigators discuss how they apply clinical research in care of patients with prostate cancer. I'm Dr. Elisabeth Heath, and I'll be moderating this meeting today. This is our faculty, an esteemed group. We'll have Dr. Aggarwal from University of California, San Francisco, Dr. Kibel from the Brigham and Women's Hospital, from Dr. Klotz from the University of Toronto, and Dr. Srinivas from Stanford University, and myself as your moderator. Our next set of slides are all of our relevant disclosures, and these are also relevant to consulting faculty and research to practice conflicts of interest. This program will contain discussion of non-approved uses of agents and regimens, so please refer to the official prescribing information for each product for approved indications. All right, so this is where we're going this morning. Our esteemed panel will be talking about a variety of relevant topics that's facing us in clinical practice. We'll begin with Dr. Kibel for Module 1, reviewing the recent data defining the optimal use of hormonal therapy for non-metastatic prostate cancer. And then that will be followed by Dr. Klotz, who will review side effects and other practical considerations with hormonal therapy for non-metastatic prostate cancer. And then Dr. Aggarwal will review the current and future approaches to hormonal therapy for metastatic prostate cancer. And Dr. Srinivas will review new consideration for the use of PARP inhibitors for metastatic castrate-resistant prostate cancer. And then I will finish up by talking about other novel therapies for patients with metastatic prostate cancer. In order to make this meeting more relevant, Dr. Love interviewed Drs. Jason Hafren and David Morris about a number of key issues related to the management of prostate cancer. And excerpts from these videos will be shown and discussed by the faculty panel throughout today's program. Okay, so we're going to hear this morning, right off the bat, from Dr. Love in his conversation with Drs. Hafren and Morris about the optimal use of androgen therapy for M0 disease. Let's see the first video.
Good morning, everyone. I'm Neil Love from Research to Practice. To make this continuing medical education event more relevant, we work with urologic oncologists Dr. Jason Hafren and Dr. David Morris to plan this meeting and to directly query the faculty on the stage about a number of key issues in the management of prostate cancer, beginning with a focus on localized high-risk disease, which, as in all stages of prostate cancer, now involves the consideration of endocrine therapy intensification.
Based on current literature, when would you consider LHRH therapy alone? I think what we see today is that that space is shrinking and that space is being challenged at many levels. Stampede showed that in patients with very high risk, and this is not NCCN high risk, there's a benefit to adding abiraterone to ADT. My question to the panel is, have you extrapolated the Stampede data to apply that as a standard of care within your practice? The definition of high risk based on Stampede is not the traditional patient we're seeing in the clinic. And does that definition apply to our everyday patient? We've seen some success with abiraterone used in combination with ADT, but what about the other agents, enzalutamide, apalutamide, or darolutamide? Is there any role for those agents to be used in combination for localized high-risk or very high-risk radiation patients?
The question for the panel is, if you were treating a high-risk patient with ADT in combination with radiation, the guidelines would have always supported 18 months to 3 years of ADT. But if you're intensifying on top of that, are you shortening the interval? What is your ideal duration of combination? Are you using Stampede as kind of a 2-year combination treatment?
Okay, really relevant questions facing us this morning. And you see the questions here as posed by Drs. Hafren and Morris. I think I'll start with Dr. Srinivas. What are your thoughts here on the very first question posed by Dr. Hafren? Have you extrapolated the STAMPEDE data and applied that as standard of care for your practice with patients with high-risk localized prostate cancer? Understanding that we're medical oncologists and maybe we don't see as many, but I think the referrals that we're seeing is sort of a vote on whether we think we should or not. So thoughts?
Well, definitely we are seeing more and more of these patients being referred to us. Almost all patients who are getting intensification are being referred to medical oncologists. So I would definitely say this is very relevant to our practice. I also think on one hand that the use of these drugs have significantly increased, and they come with a high price in terms of toxicity as well. So I do think a lot about for which patient is it relevant to intensify and which patient can just do with the standard 18 months of LHRH alone. I follow the very high-risk group NCCN category, so these patients who have a high group 5, patients who have T3 disease, who are the very high-risk category for whom I do intensification with abiraterone.
Now, that's really helpful and certainly relevant to everyday practice. Dr. Aggarwal, would you substitute another AR pathway inhibitor, any one of these listed, apalutamide, darolutamide, or enzalutamide, for abiraterone in this instance?
Yeah, I mean, I think that, they clearly have differences in toxicity profile. With abiraterone, you certainly have a little bit higher risk of fluid retention, hypertension risk, potential risk for worsening diabetes with the prednisone that we give with them. That being said, it is good to follow the data. And right now, when we look at the high-risk localized setting, the best level 1 evidence we have is from STAMPEDE. It's worth saying that STAMPEDE group is a very high risk, so 2 out of 3 of PSA over 40, Gleason group 4-5, or T3. And so it's a very high-risk localized group. For that group, I do offer abiraterone. I haven't tended to deviate from that and offer one of the AR inhibitors.
Yeah, absolutely. And your thoughts there, Dr. Klotz? Same question. Would you substitute?
Yeah. Well, I think, one of the limits of relying completely on clinical trials is that the design of the trial, which may have been established a decade ago, tends to drive current practice sometimes beyond what one would consider common sense. So I think this is an example where the fact that the studies that we are relying on, STAMPEDE, for example, used abiraterone, should not be used as a rationale for restricting treatment only to abiraterone. And all the data we have from now so many trials is that the survival benefit of these drugs looks pretty much equivalent. So I consider them, from a survival perspective, more or less interchangeable. The issue then becomes trade-off of side effects. And as was mentioned, there's definitely different side effects between these drugs, different patients who are better suited for one than the other.
And Dr. Kibel, since this is going to be your module, just thoughts on the duration of ADT that you would recommend?
So, I think one of the nice things is that some of these drugs have the opportunity to give patients drug holidays for periods of time. You're not putting people on a lifelong androgen deprivation. Let's face it, what the patients hate about radiation in particular, but hormone therapy in general, is the hormone therapy and the side effects, particularly the hot flashes, but also the cognitive issues, the muscle and bone issues, and it makes them feel old, so they don't really like taking it. So giving patients, intensifying the therapy early, giving them a drug holiday, allowing them not to necessarily have it for as long a period in the future, I think is a big win if we discuss it with the patients in that frame.
Yes, Dr. Klotz?
Yeah, if I can just add to that, I think there's a key concept that is not that widely appreciated, which is that we have now so much data that intensification of the androgen receptor targeted pathway offers a better outcome, but that does not mean it has to be permanent. In other words, you hit hard and then stop. And this is the basic concept of intermittent therapy, which goes back now almost 4 decades, still a controversy. And I think, just to emphasize the point, that I would call this the intermittent therapy approach is still extremely valid, notwithstanding that we know that treatment intensification is preferred when you're giving the treatment.
That's a great answer. And I guess somewhere in today's discussion, we'll also talk about the different types of ADT. Perhaps that concept of intermittent with the oral agents now may be a different way of interpretation. But these are terrific ways, I think, to think about the data, especially in everyday practice. Well, let's hear from our faculty again for a topic where incorporating ADT occurs in the salvage and in the perioperative settings.
Our consultants had many other questions about the management of localized high-risk disease, including the following.
In terms of radiation salvage therapy, most of us are doing short course ADT with it now based off the SPORT trial. Question for the panelist is, in this era with imaging and somebody having a recurrence after surgery, are you combining ADT consistently in those patients having salvage pelvic therapy? And if you are combining ADT with it, what is your agent of choice? Is it an oral agent? Is it an injectable agent? And are you doing combination therapy in those patients who have no evidence of any metastasis or nodal involvement on imaging?
Is there any role for ADT in surgical patients with high risk and very high risk disease? Is there any role for ADT intensification? What about chemotherapy? We've seen multiple negative trials regarding chemotherapy, but is there any role in 2024 for chemotherapy in high risk or very high risk patients undergoing surgery? In the post-APA-RP trial, where a year of apalutamide with ADT was used, we saw no evidence of biochemical recurrence. Historically, biochemical recurrence rate was 76% in this patient population, which questions whether there's a role for these very strong ADT agents to be used in combination with surgery. Currently, there's a trial called the Proteus trial that is looking at apalutamide plus ADT 6 months prior to surgery and 6 months after surgery. The results haven't been released yet, but if positive, would you consider using ADT plus apalutamide in your surgical patient population?
Absolutely relevant questions again, and yes, I'll this time pick on Dr. Kibel to go first. Are you combining ADT with salvage pelvic radiotherapy for patients with recurrence after surgery?
Absolutely. I mean, I think it's sort of become the standard of care. I think the question is how intense it's going to be. I think there are groups of patients that you can hold back and not give the androgen deprivation using things like a decipher to pick and choose the patients that need more intensification. But then the flip side of the coin is the patients that have the higher risk need additional androgen deprivation beyond the standard.
That's terrific. And I guess, Dr. Kibel, do you make that decision perhaps with the radiation oncologist, or is this something you feel quite absolute about, or is there room for negotiations?
I think there's room for negotiation with the patient. As I stated earlier, the patients really want to avoid androgen deprivation. Clearly, you want to respect the patient's autonomy as long as they understand the pluses and minuses. It doesn't mean that radiation therapy alone doesn't work. It just works better if you give it in combination. I'm very fortunate to work with some outstanding radiation oncologists like Paul Nguyen and Anthony D'Amico. Paul Nguyen, for instance, is very involved in clinical trials tailoring the use of androgen deprivation on the basis of genomic scores. And so we have a lot of trials that are open right now to try and tweak that a little bit to understand who's going to benefit and who's not.
No, that's great. And again, a reminder for all of us, when possible, please enroll your patients or refer for a clinical trial so we can get more information and have that. Dr. Klotz, what are your thoughts there?
Well, just to emphasize the point, I think most people know that the commonest cause of death in men with PSA failure, which is essentially the scenario we're talking about here, is cardiovascular disease. And the concern is that we're going to take someone who's really not very much at risk for prostate cancer mortality based on, say, late, slow PSA rise, and give them a whole lot of therapy that may significantly impact their quality of life. So just to emphasize the absolute critical importance of risk stratification in this group of patients, not go overboard with intense ADT therapy used adjuvantly to salvage radiation in the elderly patient who's got very indolent PSA recurrence, and obviously vice versa.
Absolutely. And Dr. Aggarwal, are you recommending ADT combination therapy for those without metastasis or even nodal involvement?
Yeah, I mean, I think in the recurrent setting, when you're giving with salvage radiation, we generally have been getting PSMA PET imaging on all these patients prior to radiation. And for those that are PET imaging negative, where there's no nodal involvement, where we're doing salvage radiation, we generally have been following the data and giving single agent ADT for those patients. I think we're going to talk about the recurrent setting where we're not following salvage radiation using the EMBARK data, but when you're giving with salvage radiation, generally we'll use the PET scan to help guide our decision making.
Yeah, absolutely. And Dr. Srinivas, we are again getting a lot of consults now for the high risk and very high risk, whether it's for radiation or surgery. What are your thoughts there in terms of role of ADT in those going towards surgery? Any role at all, or what about in combination, or even Dr. Hafron's question of the role of chemotherapy in this setting?
Oh, no. I think for surgical patients, at least the prior trials that have been done in the past have really not supported the use of ADT preoperatively. So I think there are trials that are ongoing. So till those trials read out, our approach is really just to send those patients to surgery. I just wanted to comment a little bit on one of the previous questions about salvage radiation. I think we are doing radiation much sooner these days with a very, very low PSA. So I think, again, the role of de-escalation is definitely something that's in our mind. Are there a group of patients who are getting a good dose of radiation with really PSAs that are at 0.2 and much earlier? Could they go by without the use of ADT? And again, the use of Decipher and some of these genomic assays are really helpful in guiding them. And I think there are ongoing trials to help address that as well.
Wonderful. Thank you so much for your thoughtful questions. I think, Dr. Kibel, actually, you can come up here because it's your turn to do your presentation for the
As I wander up, I was going to comment on the Proteus trial, which has been locked, and I'm not going to talk about it today. I'm one of the PIs, along with Mary Ellen Taplin, so hopefully we'll have results on that soon and be able to answer some of these important questions about treating our patients systemically with high-risk disease. Okay, so the task I've been given is to discuss a non-metastatic, hormone-sensitive, and non-metastatic castrate-resistant prostate cancer. So these are the 5 trials that I'm going to discuss: EMBARK and PRESTO, and then in the non-metastatic castrate-resistant state, PROSPER, SPARTAN, and ARAMIS. And I'm going to spend a very brief time talking about future directions. This is the EMBARK trial, really a very important trial that was just published last year. The eligibility are very important. These are patients who had an elevated PSA after they were done treating the pelvis. So they either had a radical prostatectomy and radiation or radiation therapy alone. Relatively high PSA when they were put on the study. Rapid PSA doubling time. They were not castrate, and this is also important. They had negative imaging by CT and MRI, conventional imaging, not PET. So importantly, the arms are important. So there's enzalutamide and leuprolide, placebo and leuprolide, so standard, and then enzalutamide alone, randomized 1 to 1 to 1. And then we were talking about earlier the drug holiday piece, all the way over at the end. If their PSA was less than 0.2 at 36 weeks, they were given a drug holiday, and the drugs were stopped. So this is the leuprolide versus enzalutamide data, shows a clear benefit to the enzalutamide alone arm, which was fairly substantial. The hazard ratio is 0.63. And this is the data on the enzalutamide plus leuprolide versus leuprolide alone. These endpoints are metastasis-free survival, not overall survival. And you look at these and you think maybe the enzalutamide and leuprolide arm is better than the enzalutamide arm alone in the prior slide, but you can't really do that. That's not how the study was set up. In my opinion, it's a little unfortunate that wasn't done, but studies are designed with the best of intentions. Hidden in the supplemental data was data on overall survival for the leuprolide and enzalutamide arm versus leuprolide alone, and the top curve is the combination and clearly shows a survival advantage with a hazard ratio of about 0.6, which is impressive. Basically, every endpoint did better, favored enzalutamide on the left. So metastasis-free survival, overall survival, PSA progression, use of additional agents, so the patient stayed off of additional agents for a longer period of time, very important to the patient, resumption of any hormonal therapy, development of castrate resistance, all of those things favored the combination arm. So a win, basically from any aspect that you think about it. And the bottom one is the FACT-P score. That means the patients didn't have any more side effects than leuprolide alone. This is the data on the drug holiday piece. So what it shows you on the left is enzalutamide combination with leuprolide. Then you have leuprolide alone and enzalutamide monotherapy. And you can see that the drug holiday, 90% of the patients achieved a PSA of 0.2 or less in the combination arm. And I think it was pretty substantial in the other two arms as well. And on the right, you can see how long they were off of drug. And in the combination arm, they were off of drug for almost 2 years on average. Okay, I think that's important on average. That means some patients were off it for years afterwards. Okay? The second trial to discuss is the PRESTO trial. This is a very similar trial, looking in this case at a more intense regimen using apalutamide alone. So it's LHRH, apalutamide, or apalutamide and Abi. Okay? Prior radical prostatectomy. They could have had a salvage radiation or not, but they had to be ineligible for salvage radiation. So you're done with your pelvis. No metastatic disease, again by CT and bone scan. Interestingly, in this trial, they could have had a PET scan, but if the PET scan was positive, it didn't enter into the decision-making about whether to be on the study or not. PSA a little more elevated, a little lower at 0.5, but the same PSA doubling time, the same non-castrate state with a normal testosterone of greater than 150. Slightly longer treatment at 52 weeks. They were stratified by PSA doubling time, and the primary endpoint, which is different from the EMBARK trial. In the EMBARK trial, it was metastasis-free survival. In this study, it's PSA recurrence, and then the variety of usual secondary outcomes. So 503 men were randomized, about 166 in each arm. Again, a smaller trial than EMBARK, where it was over 1,000 men that were randomized. About 63 are still on treatment when they published this study. Median follow-up was 21 months. In the EMBARK trial, it was close to 60 months, so a shorter duration of follow-up. And at 5 years of follow-up, there was improved biochemical recurrence-free survival for all the apalutamide arms. So on the left, we have the LHRH versus LHRH plus apalutamide, and you can see a clear benefit to the combination. The improvement was approximately 5 months in total. And if you look at the more intense therapy, which was LH, APA, and ABI, you can see that the improvement was approximately the same at about 6 months. So in this hormone-sensitive biochemical recurrent state, I think it's important to remember that in all these trials, we had local therapy first. The patients got radiation with ADT. We have good data on ADT intensification with apalutamide and abiraterone with radiation therapy. It's also in the STAMPEDE where there was abiraterone with enzalutamide in addition. Formula 501 is a trial that was done by Paul Nguyen at our institution, which it was the one that intensified therapy also in the hormone area with apalutamide and abiraterone. And therefore, I think that this is an important thing to remember as we're considering giving patients additional therapy in this non-metastatic castrate-sensitive state. The treatment intensification was slightly different, shorter in the EMBARK trial. PRESTO trial, a little more intense and a little longer therapy. The endpoints were different, but I think they've given us the same message, which is intensifying the therapy will improve the outcomes for our patients. So these are the three trials in the non-metastatic castrate-resistant state, almost essentially identical eligibility requirements, a 2-to-1 randomization. All of them showed an improvement in metastasis-free survival, and recent data shows an improvement in overall survival for all of them with a hazard ratio of about 0.7. This is the data on PROSPER. This is the metastasis-free survival. This is the data on overall survival showing a clear benefit with a hazard ratio of 0.7. Very similar data for SPARTAN showing an improvement of about 24 months in metastasis-free survival. And again, an improvement in whether the patients were alive or dead in terms of overall survival, with an improvement of about a year. Interesting, a lot of the patients crossed over in Spartan, so this additional analysis showed what would happen if you did not cross over, and you see that the benefit is probably more intense and more beneficial. Same story with Artemis. This uses darolutamide and showed a very similar benefit in terms of metastasis-free survival and a very similar benefit in terms of overall survival. The take-home message on these trials is all three drugs improve the outcome. Less toxicity, maybe with darolutamide, and Dr. Klotz is going to go through that a little bit. At the end of the day, there was no difference in overall grade 3 toxicity between the trials, so I think it's a little bit of you choose which one you want. I was asked to talk about future trials. I don't think there's a lot out there right now. These are the two trials that I could find. The ARISTEP is very similar to EMBARK, but using darolutamide. The Primordium, I think, is very interesting because they're going to use PET imaging as a primary endpoint, and PET imaging has profoundly changed our management of this disease. So quickly, future directions. I think that non-metastatic castrate-resistant prostate cancer is disappearing. Conventional ADT is not really guideline supported in this area. Increasingly, due to these trials, patients are going to get the treatment even earlier, and PET imaging is redefining metastatic disease. And the non-metastatic hormone-sensitive prostate cancer, I think, is also going to be redefined due to rapid PSA doubling time, PET positivity or negatively, and increasingly using biological markers. Thank you very much.
Thank you, Dr. Kibel. And as you're taking your seat, I think there was a question from the audience in terms of should this patient population all get PSMA PET as a standard?
Yes.
We'll probably come up on that theme again, as I think our audience here in person as well as virtually has different guidelines and coming from different parts of the world. So the topic of access and availability of PSMA PET is something that becomes practical in nature. But we will now move on to our second module, because with all of these conversations come real considerations of our patients with their side effects and how do we really think about them for patients in this non-metastatic setting. And we're going to hear now from Dr. Love and Dr. Morris about ADT intensification in this biochemical recurrence setting.
The 2023 AUA meeting included one of the most important presentations of this or any year in clinical research in oncology, the EMBARK trial, which unleashed a torrent of clinical and research questions that include the following.
The biggest question in the community is how to classify these high-risk recurrences in an era of conventional imaging being surpassed by molecular targeted therapy and PSMA PET imaging. Obviously, the recent publications all based on conventional imaging, where we know most of the patients in that category screening for that study would likely have something found on a PSMA PET. Do they treat them any differently? And in patients that you're presenting the option of kind of EMBARK-like therapy as intensified for PSA-only disease after recurrence, how important is it to make sure that patients have had full pelvic therapy and completed all potential salvage options before they move to ADT therapy? For somebody with high-risk BCR who you're doing this intensification with ADT and adding enzalutamide, how often are you moving and offering a holiday to those patients? And then what are the triggers that you're using to restart after a holiday period? And then are you reoffering a holiday, which was not done in the trial? Are you considering doing intermittent combination therapy like some other trials have done, even though that trial only had one holiday period built into it?
Excellent question. I think something we face all the time in our clinical practice. So, Dr. Klotz, how important is it to have your patients with PSA-only recurrence complete that full pelvic therapy and all other potential salvage options before really pursuing an EMBARK-like treatment approach?
Yeah, I think it's quite important. Fundamentally, the adverse effects, if you let's say assume the patient's not at that much risk from prostate cancer mortality, it becomes a question of comparing quality of life effects of radiation plus or minus short-term ADT, intensified or not, with long-term delayed salvage ADT alone. And I think the long-term effects of ADT are really much worse than the effects, the quality of life effects of radiation in the vast majority of patients. So I think by and large the approach is to treat locally, try and eradicate the disease, if for no other reason than to delay or completely avoid the need for long-term ADT down the road. So yes, give radiation therapy first, plus or minus the adjuvant ADT, and then see what happens.
Thank you so much. Now, Dr. Aggarwal, when patients come to you and say, what's your approach for treatment holidays, what do you advise them, especially when you're quite concerned about their high-risk biochemical recurrence, they're getting maximal therapy? What's your definition of intermittent, and what's your definition for actually a holiday? What does that mean to you?
Yeah, I mean, I think that, we have data going back many years from the intermittent versus continuous ADT trial in biochemical recurrence, well before the days of PSMA PET or intensified therapy, but nonetheless that showed us that long-term survival was non-inferior when you take a true intermittent approach, which to me means on cycles, off cycles, on cycles, rather than just one treatment holiday as was used in the EMBARK study. So we do offer intermittent therapy quite often. I think what's changed is we're detecting low volume metastatic disease based on PSMA PET. And so do we take an approach of intermittent but intensified therapy? And there are trials ongoing really asking that question, but I think from a pragmatic standpoint, we do apply that sort of intermittent principle for patients that have a optimal nadir, a PSA less than 0.2 on treatment.
Now, Dr. Srinivas, do you utilize the recovery of testosterone to help define these holiday periods or intermittent scenarios?
Absolutely. So for patients, once it's a shared decision-making about taking this approach of intermittent therapy. Once that decision is being made, the surveillance for those patients include both a PSA as well as a testosterone. And testosterone recovery really is the key to determine when you're going to put that patient back again on therapy, should the PSA start rising.
Yeah, now I'll pose the same question to Dr. Kibel. What's your definition?
My definition of what? Of failure?
Of intermittent therapy and holidays.
A holiday, I think, so this is a very practical approach to this, and I think we're still learning in this space how this actually works. What you'd like to do is institute therapy on the basis really of how fast it's going up. But the problem with that approach is it's very hard to sort of keep track of that. So generally what you do with a patient is set a cut point, and when you reach that cut point, then you go ahead and institute it. I think in the EMBARK trial, I'm doing this from memory, I think it was 5 was the PSA in which they restarted. So I would say that to the patient and then reassure them when the PSA is less than 5, you're doing great. Your PSA isn't less than 5. Take a negative thing and turn it into a positive thing.
That's a great, I think, piece of advice that's quite practical. Dr. Klotz, you had a comment?
Just 2 points. We did a relatively small but still pretty clear randomized trial of the different durations of induction for patients going on intermittent therapy, randomized between 4 and 10 months. Absolutely no difference in the duration of the off-treatment interval. And in my view, the implications of that are that you basically treat till you get PSA nadir of less than 0.2 or 0.02 and then stop. And in many patients, that may be 3 months of therapy. So there's no need to have a prolonged period of induction if they have a great biochemical response. The other caveat in this area, and we learned this the hard way in the large PR7 trial, which was the Canadian-led trial of intermittent versus continuous in non-metastatic disease that's kind of relevant to this question. You get patients who develop occult metastatic castrate resistance during the off-treatment interval because their testosterone is still suppressed, particularly once you get out 2, 3, 4 cycles of therapy. So you have to be aware that even in the off-treatment interval, these patients may develop, in some cases, metastatic castrate-resistant disease.
Great point. Thank you for that. Let's hear again from Dr. Love and Dr. Hafron on the practical application, as we've been talking about. with this EMBARK data in the management of patients with high-risk biochemical recurrence?
Two unique and really breathtaking aspects to the design of the EMBARK trial were first the presence of an enzalutamide monotherapy arm, and secondly, the initiation of a treatment holiday after the response to therapy. Here are a few of the dozens of questions raised by this landmark study.
The EMBARK trial is one of the most exciting trials I've seen in many years. So based on the EMBARK trial, how are you applying that into clinical practice? How often do you image these patients? The other thing that EMBARK was interesting and exciting was that there was 3 arms. Based on the results of the trial, is there any role for enzalutamide monotherapy? How do you manage the side effects of enzalutamide monotherapy, which appear to be significant, primarily related to breast discomfort, breast enlargement, and nipple tenderness? It's recommended to consider radiation to the breast. Will that affect or will that improve the gynecomastia, or will that just affect the nipple tenderness and the pain associated with this agent? What's the difference in hot flashes, and what was the difference in sexual function? Having testosterone still available, did that make a difference for these patients with their adverse event profiles?
Excellent questions from Dr. Hafron, and I'll pose the first one actually to Dr. Kibel, since you're quite familiar with the EMBARK data. In which situations are you considering enzalutamide and ADT for patients with biochemical recurrence after local therapy? What about monotherapy?
So I think we're really wrestling with this right now in the clinic. I mean, I wish I could give you an easy answer, but I'm very struck by the fact that the overall survival data was only really published, at least the only data I can find is in the combination arm. And the drug holiday period was actually better if you got the combination therapy than if you got the monotherapy. So I think you're trading off a lot of side effects associated with it. I think the question was highlighting quite nicely about the radiation. You should radiate the patients that are their breasts if they're getting monotherapy. I do think the sexual side effects are less when patients get monotherapy as opposed to the combination. So there's a trade-off when you're discussing it with the patient, and I think the patient sort of helps determine which one direction they actually want to go. I'm going to be very curious to listen to Dr. Klotz's talk, because I think he'll be highlighting a lot of these things.
Well, absolutely, and maybe we'll save that a moment there, Dr. Klotz, since I know your presentation is coming up here. But Dr. Aggarwal, we have a lot of experience with enzalutamide, especially in the mCRPC setting and as well as the hormone-sensitive setting. What do we tell our folks who are in this earlier setting with regards to their experience of hot flashes and sexual dysfunction, and what do we do with testosterone?
Yeah, I mean, I think it's a great question. Enzalutamide for many patients is not always the easiest therapy. I do think with monotherapy, if you look at the EMBARK data, the risk of hot flashes was less, and I do think sexual side effects are less. On the other hand, the painful gynecomastia is higher, and some of the other bothersome side effects of enzalutamide, such as risk of falls, cognitive effects, fatigue, asthenia, can be pretty problematic with enzalutamide. So I think it is a balanced discussion with patients when we're thinking about monotherapy versus the combination. The other important thing with a monotherapy is you're not getting as much of a break. If you look at the EMBARK study, a much shorter, I think median 11 months off treatment. No surprise, you have supraphysiologic testosterone, and that's going to drive a shorter time to PSA progression.
Oh, great points. And I think to that, I invite Dr. Klotz to come up here and share his thoughts on these side effects and other considerations.
Thank you. So just first some thoughts, and this is a big topic and a lot of the issues have been raised already. First of all, PSMA PET has resulted in dramatic stage migration. So the term ADT for non-metastatic prostate cancer, I interpret as essentially the treatment of biochemical failure after local measures have been exhausted. And obviously this PSA-only recurrence stage is disappearing, and particularly once the PSA is above 0.5, the vast majority of these patients will have positive PSMA PET scans showing some disease, and in the majority of cases, the disease is not just a local recurrence, particularly in the post-prostatectomy situation. The second is, when should we be initiating therapy? And there was a strong trend, mainly, I think, driven by financial considerations in the 90s and the 2000s to initiate ADT very early, just barely detectable levels of PSA, and this was wrong, and I think widely accepted now, that you should wait, and how long you should wait, there's not great evidence for. The best evidentiary basis is EORTC 30891, published by Studer about 15 years ago, that was randomized trial of early versus delayed ADT as primary therapy, so it's not completely relevant, but you look at the thresholds that were supported by that study, a PSA of 20 in men less than 70 and 50 in men over 70. So these are much higher levels than we use conventionally. And I think the message, since that's really the only randomized study that addresses this, is don't rush in. And we have the study by Duchenne, which was also an early versus delayed study that showed a modest benefit of early treatment, not waiting for metastatic disease, but no PSA levels in that study. So the message is that the survival benefit that we're focusing on of treating with ADT in the PSA recurrent space is modest, and you have to weigh it against the known adverse effects. Intermittent therapy, I happened to publish the first clinical trial, clinical study of this almost 40 years ago, and it's still controversial. And as we've just heard, there very much is scientific evidence, preclinical and clinical, supporting the idea of intensification not being inherently a contradiction to the idea of stopping therapy. You hit hard. When you stop treatment, the biologic concept is you have reinduction of the apoptotic potential. In other words, the re-exposure to testosterone reinduces androgen sensitivity. There's a lot of evidence for that preclinically, not so much clinically, but it very much has a role in the current era, although we really need trials to support that. And finally, as we've also heard, what's the significance of finding, for example, 1 or 2 minimally involved lymph nodes on PSMA PET compared to conventional nodal staging? And for example, in the intermittent versus continuous trial that I mentioned earlier, the median time to prostate cancer mortality was somewhere in the 10 to 15 year range. So that's probably the natural history of these patients with PSMA-only minimal nodal disease, really long-term survival, and therefore it's somewhat of a different clinical scenario than the patients who have disease on conventional imaging. So the next topic is the issue of the side effect profile of treatment intensification, and definitely the best data on this comes from the EMBARK trial in the biochemical recurrence scenario. So first of all, fatigue is very much a feature of enzalutamide treatment, and I think everyone who uses this drug is aware of that. And if you compare, for example, in that top box, fatigue, enza plus luprolide versus luprolide alone, it's 42% versus 32%. These patients are kind of dragging their butts as they come into the office. And I think that, to me, is very much a limiting factor in the appeal of enzalutamide and apalutamide in this scenario. Darolutamide seems to have less fatigue effects, although they've not been compared head-to-head. Hot flash is pretty much comparable. And then if you go down to the second box, gynecomastia. So gynecomastia with enzalutamide monotherapy, 45%. This is a real issue for patients. We have historic data on the effect of radiation in patients getting bicalutamide alone, and it reduces the gynecomastia only in about 50%, that is breast radiation. So these patients get very much gynecomastia. Some of them end up having breast reduction surgery because they just find it so unsightly. So for that reason, I am not a big fan of enzalutamide monotherapy, and perhaps I'm also biased by the earlier bicalutamide monotherapy studies from 20 years ago, which showed that it was inferior to LHRH agonist in terms of prostate cancer mortality. Maybe different, enzalutamide obviously a much more potent drug than bicalutamide. We've heard about the impact in intermittent therapy of testosterone recovery. Obviously, testosterone goes up as a reflex in response to enzalutamide monotherapy, and then goes down when treatment's suspended, comes back up versus the leuprolide. So this is clearly a benefit in men who are young, who are sexually active, and it's a trade-off. They've obviously got to deal with the gynecomastia, and the still unanswered question, because we didn't have that in EMBARK, is combination with enza plus leuprolide superior or not in terms of overall survival to enzalutamide alone. This shows some of the quality of life effects. So this is pain, the top one, really no difference. But if you go to, you see there are differences in quality of life, physical well-being and social family well-being favoring leuprolide alone. Again, this is mainly, I think, the fatigue effect. Emotional well-being, better with leuprolide than enzalutamide combination. This is, again, the physical well-being, and this compares enza monotherapy to leuprolide alone on the right, and again, favoring leuprolide in those comparative analyses. And this one is the sexual functioning, definitely better with enzalutamide. So it's a classic trade-off of some sexual function, quality of life benefits against fatigue. And this one shows the sexual activity score over time. The blue line is the enzalutamide monotherapy. So sure, there's definite benefit in terms of sexual activity score, and I think for a minority of patients that may make that approach well worthwhile. I'm just going to cover a couple of other aspects of ADT that I think are controversial and maybe not that well known. This is the issue of agonist versus antagonist. This has been a controversy in the field for the last decade. Why should there be a difference? Because inflammatory cells express GnRH receptors. These cells are in endothelial plaques, and if you stimulate them, you can get plaque instability and increased risk of thromboembolic events. And this is from the HERO study, which was the relagelics versus leuprolide. And in the patients with a history of MACE, major adverse cardiac events, about a 5-fold difference in adverse cardiovascular events. But you see that it says any grade, which is really grade 1 or 2. And people ask, what is a grade 1 or 2 major adverse cardiac event? And I still haven't really been able to get an answer to that. Probably because once the patients are hospitalized, it's a grade 3 event. It's probably a non-STEMI or a TIA, something like that, but there was a 5-fold difference. And then you had the pronounced study that showed absolutely no difference between degarelix and leuprolide, probably the reason being the impact of optimization of cardiovascular health in the patients in this trial. So, and this is a meta-analysis that I was involved in that incorporated all this stuff, and it did tend to show a difference in cardiovascular events and cardiovascular death in patients at risk with the antagonist versus the agonist. So bottom line is, I don't think we know the answer to this, and I don't think we're never going to have complete certainty about the answer. There was a trial launched of relagelics versus leuprolide by the relagelics folks, and that trial was closed recently, not coming anywhere close to accruing its cohort. And just a couple of other points that I was asked to address, the issue of CNS effects. There was no evidence in the EMBARK study that this seizure issue, which was seen in some of the earlier enzalutamide studies, was a problem. It may have just been serendipity in those early studies, no difference in dizziness or falls, no seizures reported. So I think that's somewhat reassuring. And then finally, I just want to address some of the ADT effects that we don't look after too well. The issue of loss of bone mineral density and fracture risk, 40% roughly increased risk of fracture. This is a study we did of alendronate in men getting a year of leuprolide. So this is kind of relevant to the PSA failure study, and basically you give one pill a week of alendronate, they gain bone mineral density rather than lose it. This is a meta-analysis of all the different drugs that have been given for this. They all work, whereas calcium and vitamin D doesn't work despite it being in every single guideline. And the final point I just want to make is metformin, a gorgeous drug for men on ADT. Nobody uses this. There's 2 randomized trials showing that metformin reduces abdominal girth, weight, BMI, and blood pressure in men on ADT. I don't know why this isn't more widely used, but I use it in all patients on NDT. And to keep this all straight, the A, B, C, D, E's, and F's of men on ADT, just to keep in mind all the various adverse effects, most of which we can improve with innocuous interventions. Thank you very much.
Thank you so much, Dr. Klotz. That slide is, I think, very helpful to keep everything straight. I know we're going to have a more in-depth discussion in this next module where Dr. Aggarwal in a few minutes here will talk about the different approaches, but let's hear again now from our esteemed Dr. Love as well as Dr. Hafron, a discussion here about more on ADT of doublet versus triplet therapy, and then as well as the role of radiation therapy. I think with us intensifying, it's keeping with some of the relevant points that Dr. Klotz had brought up so that we can really serve our patients to the best of our ability. Let's hear what Dr. Hafron has to say.
Endocrine-sensitive metastatic prostate cancer has been the subject of a number of major phase 3 clinical trials, and in addition to clearly demonstrating the value of intensification of endocrine therapy, the residual question is the role of chemotherapy.
We've seen 2 great trials recently, PEACE 1 and Arison's trial, that show the benefit of triple therapy. When do you apply triple therapy in your clinic? When would you just use doublet therapy? How do you decide?
How do you decide?
In my clinic, when I have a patient who's chemo fit, who has high volume de novo disease, I'll typically refer him for triplet therapy. It's in the patient who has oligoprogressive or low volume disease, I typically would just go with doublet therapy. In patients with metastatic disease, is there a limit to how many metastatic sites you can target with radiation therapy? How are you applying metastasis-directed therapy in advanced disease? What are your rules and guidelines at this point?
Such relevant questions. We're all facing this every day in seeing our patients. Dr. Srinivas, what are your thoughts there on how you decide doublet versus triplet therapy in this setting?
I think I agree with Dr. Hafron. The triplet, it appears that docetaxel adds the most value for patients with de novo disease and who have high volume disease. And I completely agree with him that the first assessment is the patient chemo fit? So I tend to do exactly what Jason is suggesting.
Absolutely. And let me ask Dr. Kibel, in your urology practice, when do you refer for patients with for potential triplet?
I mean, I agree with what's been said previously. I think the only other things that come into my mind are the age of the patient. I think a younger patient deserves triplet therapy. Again, that probably is just a surrogate for how chemo fit they are. And then the other piece of it is how rapidly the PSA is going up. I think those patients, even if we can't find any, even if the metastatic disease seems to be less, I think that just tells me that we're not detecting it and that patient should have intensification.
Dr. Klotz, do you do the same in your practice?
Yeah, I do the same, but there is a major gap in the evidence, which is that we now know from these trials that adding darolutamide to docetaxel improves the outcome. We don't have a study of darolutamide plus or minus, or one of the other ARPIs plus or minus chemo. So there's still some uncertainty about whether patients would be better off in the majority of cases getting what is, after all, single agent chemotherapy, not that toxic, kind of move to the less than just the most high risk patients.
Yeah. Dr. Aggarwal, what are your thoughts there in terms of when you refer to radiation oncology for any one of these low volume metastases? Do you do that in addition to?
Yeah, I mean, I think for the data that we have from Stampede shows for low volume metastatic CSPC patients that treating the primary does seem to improve long-term outcomes, and that survival advantage is actually strengthened with longer-term follow-up from that cohort. Now, that was done before we intensified, so there's still some sort of uncertainty there in that setting, but I think some of the additional studies that have come out still support treating the primary. I think what's much more of a gray area is when we have low volume by PSMA PET, you treat the primary, sure, and you give doublet therapy, but then do you offer metastasis-directed radiation on top of hormone therapy? What does that gain? Does that potentially allow the ability to take a treatment break? Those are things that we have conversations with patients. It's a very individualized kind of process.
Dr. Srinivas?
I had one more thought process about this doublet versus triplet. As we keep doing genomic sequencing on these patients, there are some patients who have bad biology, such as P10 or P53, and those patients, maybe an addition of chemotherapy consideration might be something that we may learn to do more.
Yeah, absolutely. Dr. Kibel?
I was going to say, I've become a big believer in radiation therapy to the metastatic deposits and low volume disease, mostly around the decreased need for intense androgen deprivation therapy. So I'm not sure the data is really hard on this, but the patient comes in, they have a positive PSMA PET with a limited number of METs, hit it very hard with combination therapy and radiation therapy to the MET, and my anecdotal evidence is that the patients remain off therapy for a lot longer period of time, which I think is a big win for the patient from a side effect profile.
Yeah, I think it also shows how important it is to work within a multidisciplinary team. This is certainly getting, bigger and bigger, our team members, so everyone sort of gets a vote. Dr. Aggarwal, last comment?
Yeah, just, in the really low risk, slow doubling time patients with low volume recurrent disease on PET, there's also phase 2 randomized data that you can do MDT alone and potentially delay the need for restarting ADT for those patients. So that's another potential option.
Absolutely. I think the next video sort of goes into, again, based on all of these, we're intensifying, we're throwing now more treatments, more radiation options. What about the side effects and how are we monitoring these patients appropriately? So let's hear from Dr. Love and Dr. Hafron.
Dr. Hafron provided a urologic perspective on endocrine therapy of prostate cancer that frankly surprised me, and I'd be curious from the faculty on the stage whether your observations line up with his in your geographic area.
Yeah, I think most urologists use apalutamide, darolutamide, and enzalutamide. They're less familiar with abiraterone. But when using abiraterone, any suggestion in monitoring use of the steroids? The urologists are intimidated by monitoring the LFTs. They're intimidated by the prednisone. Abiraterone is mostly used by the oncologist. But abiraterone does have some significant benefits. One of the challenges with some of the other agents is fatigue. I don't find so much fatigue with abiraterone.
Right. So first, do you use abiraterone in your practice, and how are you monitoring for these side effects?
So we just talked about the benefits of a multidisciplinary approach. At our institution, when patients we start giving systemic therapy, we refer to the medical oncologist. But with that said, I also think that we underutilize abiraterone in urology practices across the United States. I think it's sort of crazy that we used to give ketoconazole without even thinking about it. I mean, I'm old enough to remember giving that, and that is a very toxic drug, and abiraterone isn't. I agree with prednisone. I see these patients, right, because we're following the multidisciplinary space, and I think the patients tolerate it very well. And then the last piece, which we don't address all the time, is the economic impact of some of these drugs, particularly as we move them earlier in the disease space. They're going to be on it for longer and longer periods of time, and abiraterone is not as expensive as the other drugs.
Yeah, that's always a good point, the financial toxicity considerations in any of these discussions, especially as we're really piling on the different intensification. Dr. Klotz, in your practice, do you agree with Dr. Hafron's assessment that he's comfortable with enzalutamide and darolutamide and apalutamide, not so much comfortable with abiraterone?
Not at all. I mean, abiraterone's been my preferred drug of choice. I'm now shifting a little more to darolutamide, but to me, the quality of life of these patients is of such primary importance. You do not get the fatigue with abiraterone. Maybe you even get a little reversal of baseline fatigue from the prednisone. You have to monitor blood pressure. I tell these patients, have a blood pressure cuff at home, measure your blood pressure once a week and write it down, bring it in. You have to monitor electrolytes for obvious reasons. You have to monitor TSH, which is the main kind of non-intuitive one. They can get hypothyroidism. But I mean, it's really not rocket science in any way. And my approach is a little bit different. I'm part of a multidisciplinary team, but I follow these patients up to chemotherapy, and that's when I get the medical oncologist involved. And I think urologists who have an interest in prostate cancer should be familiar with these drugs and use them, and you don't necessarily need a multidisciplinary involvement to manage these patients until they need chemotherapy.
And I think it also underscores the different ways and how many different practices there are, especially within the United States as well as outside of the United States. Dr. Aggarwal, I just wonder, in your practice, do the urologists refer early, or are they also managing these advanced prostate cancer patients?
Yeah, they refer early. I mean, pretty much from biochemical recurrence on. So any of the ARSIs we're pretty much managing in med-onc. But I do agree that it's important for urologists to know how to use abiraterone. It should be utilized more. The quality of life, I do think, overall is better than with the AR antagonist.
Absolutely, and it's interesting. I actually practice alongside Dr. Hafron since he's in my neck of the woods in Michigan. So we do see how he practices, and again, even then, there's differences in how the urologists around me refer in versus manage themselves. So I think at this time, Dr. Aggarwal, why don't you come up and really delve into our current and future approaches of hormonal therapy and metastatic prostate cancer.
Great, thank you so much, Elizabeth. I'm going to touch on some of the data that we have in the metastatic hormone-sensitive space. So I'm going to talk about the doublet therapy. We now have extended follow-up from the multiple phase 3 trials. We've talked about triplet therapy already, but I'll just touch upon the study design and the data. And then one of the evolving areas, there's a number of different add-on agents that are being tested in the CSPC space, but one of the exciting ones is targeting the PI3 kinase pathway, which has long been sought after in prostate cancer, but maybe we're starting to make some headway. So first, let's review what the definition of high versus low volume disease is. We've talked about it a lot today already. There's really two definitions. I would say the charted definition is the one that we use most commonly when we say high versus low volume. What do we mean? High volume is anyone with visceral metastases, so lung, liver, etc., and or 4 or more bone metastases with one outside the spine and pelvis. There is the Latitude trial, which I'll show in a minute, that uses slightly different, related but slightly different definition of visceral mets, 3 or more bone mets, or Gleason 8, and you had to have 2 or more of those criteria to fall in the high-risk category. So just looking at our phase 3 studies of the doublets. So we have Latitude, that was the addition of abiraterone to ADT, Titan, which was the addition of apalutamide, and Arches, with the addition of enzalutamide. All 3 of these trials led to FDA approval of the doublets. You can see the characteristics of the patients that were enrolled on these studies. There were some slight differences. Latitude had the highest risk, with all their patients having de novo disease, metastatic disease at diagnosis. All 3 of the studies had majority of patients with high volume disease. And importantly, these were all doublet studies. None allowed concomitant docetaxel as part of the treatment plan, and very few patients had docetaxel prior to study entry. When we look at the results from these studies, it's remarkable how similar the long-term survival results are. If you look all the way to the right, you look at the hazard ratios for long-term survival benefit, remarkably similar across all 3 studies. And I think this, despite the lack of head-to-head data, I think gives us some reassurance that overall probably efficacy is similar between these with these agents. The landmark analyses likewise show very similar results. The other thing that's worth noting is that long-term survival gets better and better. These are pretty impressive landmark OS results for high-volume de novo metastatic disease patients. These are just the Kaplan-Meier curves for overall survival. I don't want to go through the details, but just shows you that the shape of the curves is very similar as well. And the separation in curves and when you start to see survival benefit can be pretty early as within the first 8 to 12 months of therapy, suggesting that some of these patients enrolled are really high-risk patients that progress quite quickly. So let's talk about the triplet therapy. We have 2 randomized phase 3 trials looking at this question. The first is the ARASENS phase 3 study. This looked at the addition of darolutamide to a backbone of ADT plus docetaxel. So all patients got docetaxel in this study. Large sample size, I think those are strengths of this study. It wasn't as heterogeneous a population as PIECE 1. The primary endpoint was overall survival. These were the primary results of the study. You can see the hazard ratio for survival showed improvement with the addition of darolutamide on top of the doublet of ADT plus docetaxel. Hazard ratio was 0.68. And importantly, we didn't necessarily see a dramatic increase in toxicity. This is maybe in contrast to the Enzamet study with enzalutamide plus concomitant docetaxel, where it looked like there was more docetaxel-related toxicity in the triplet arm. Here, the toxicity profile when it comes to docetaxel-related toxicities looked pretty comparable between the 2 arms. The PIECE 1 study was a little bit more of a complicated design. It was basically a 4-arm study that looked at standard of care ADT alone and really asked 2 experimental questions, the addition of abiraterone and then the addition of radiation to the primary. During the course of the study, docetaxel became a standard of care based on the charted study, so the study was basically adapted to allow concomitant docetaxel. So some patients had docetaxel and therefore got the triplet. Many patients had the doublet alone. If you look at the benefit of the triplet therapy with abiraterone plus docetaxel, it really looks like in the high-volume patients is where you see a higher magnitude of benefit with OS. And I think this is what drives our decision-making in terms of who do we think about offering triplet therapy to. It's really the high-volume patients that achieve a better, a more robust hazard ratio. So should we be doing triplet therapy? I think you've heard from the panelists already that there's a consensus moving towards, if we think about a 2x2 box of metastatic CSPC, de novo versus recurrent, and high volume versus low volume. In the quadrant of high volume de novo metastatic disease, I think there's a shift towards using more triplet therapy. But it's been said already, importantly, we do not have randomized data of doublet ADT-ARSI plus minus docetaxel, and that's a major gap. It's part of our conversations we have with patients every day that we just don't have. That being said, I do think the median survival times from these triplet studies is quite compelling. Meta-analyses suggest that there may be benefit with triplet therapy, not as good as a randomized study, but give us some data to support triplet therapy over the doublet. We know that androgen signaling inhibitor sensitivity can vary quite a bit, and some of these patients with de novo metastatic disease are already headed towards castration-resistant or have AR-resistant clones within the tumor. Therefore, offering a different modality of therapy really is compelling for those patients. We definitely need biomarkers. I look at the genomic status of these patients. If they have a high-risk genomic feature, particularly RB1, that is a situation where I'm offering triplet therapy to. And I think there's still room to improve based on the PSA naders. All of these phase 3 studies have shown the correlation between depth of nadir and subsequent outcomes. There's an opportunity there for further intensification. So touching upon the PI3 kinase pathway, I think this is a really interesting area. Clearly, there's a rationale. This is the most commonly genetically mutated pathway in prostate cancer. Data from the East Coast Dream Team that Wasim Abida published a couple years ago shows very clearly that this category mutations, whether it be PTEN, PI3K, point mutations, AKT point mutations, are clearly frequently mutated in prostate cancer. And there's crosstalk between the androgen receptor and PI3 kinase pathway. When you block one, the other gets upregulated. And when you give combination blockade, as shown in the bottom right, you achieve better efficacy in preclinical studies. The PI3 kinase inhibitors that came first really were limited by narrow therapeutic index, a lot of toxicity, hyperglycemia, rash, GI toxicity, and so forth. And there was bypass pathways that could get around PI3 kinase. So perhaps we go down a little bit lower and we hit AKT, which is the next node down on the signaling pathway. And this may be a promising approach. This was the IPAT study of ipatasertib that failed to meet the primary endpoint in all comers, but interestingly did show that in the patients that had PTEN loss genomically, did have a pretty robust hazard ratio when it comes to rPFS. Not enough to achieve regulatory approval for the study, but serves as important data that there may be a role for AKT inhibition. Capivasertib is another AKT inhibitor that is in ongoing phase 3 studying and actually showed really interesting data from this randomized phase 2 study with docetaxel as a randomized study with or without capivasertib. The primary endpoint was PFS. There was no benefit, but OS was improved, and in particular, those patients that had prior AR inhibitor therapy had the greater degree of benefit with overall survival. And so that really takes us to two ongoing phase 3 studies. This is the Capitello 280 study. This is giving capivasertib plus docetaxel dosed on an intermittent fashion with overall survival as the primary endpoint. And the Capitello 281 study, this is in front-comers, PTEN deficient mCRPC, abiraterone ADT with or without the AKT inhibitor. I think this is the direction we need to go, are these biomarker-selected studies looking at improving outcomes. So that I'll summarize. I think there's unequivocal benefit for the ARSIs. Triplet therapy does have a role in the high-risk patients, and we'll see as we get data with these AKT inhibitor trials.
Thank you so much. Exciting times, I think, in terms of what's to come for novel agents. We did have a question from the audience in terms of use of relugolix, an oral agent, to perhaps utilize in the ADT setting. So thoughts on relugolix with all of this intensification going on?
Yeah, I think it's a great question. We don't have a lot of combination data. There is some emerging. I think there is a concern for, potential drug interactions with some of the data that's coming, maybe less of a concern, but we just don't have a lot of data combining these oral agents with relugolix, but perhaps more to come.
And another question from the audience was the role of genomic testing and or genetic testing. Is this the setting where you should be doing germline and somatic testing? And can you expand on that a little bit?
Germline testing, absolutely, unequivocally. Every single metastatic prostate cancer patient should have germline testing, unequivocally, so yes. I think in terms of somatic testing, it's not yet impacting standard of care treatment in the CSPC setting. I do like to get it because we're going to need it. We know these patients are going to progress to mCRPC, and so I usually will do upfront testing as well.
Yeah. Dr. Klotz, do you do genomic and genetic testing in your practice?
Yes, genomic testing for sure. We do the same. In fact, even going back to early disease, active surveillance, increasingly, it's inexpensive, widely available. Somatic testing, and I'm curious to hear what Rahul says. Somatic testing is a challenge for us. Cell-free DNA, we don't really have access to on a routine basis. It's available in a limited way in a research setting. And so you're looking at either archival tissue, which may be 15 years old. It's debatable whether the radical prostatectomy gene expression 15 years ago is relevant to the patient's current mutational burden, or else you have to go back and get more tissue. So we haven't figured that particular nut out very well yet.
Yeah. And Dr. Kibel, how about your practice?
Yeah, we get... In someone who has metastatic disease, it's absolutely indicated. And I agree, sometimes it's hard to get the primary tumor, not the primary tumor, the metastatic tumor to do the sequencing. So often you have to go back to the primary, but it does give you information that's useful for the family, useful for prognosis, and increasingly useful for choosing the most appropriate therapy. I would disagree with Dr. Klotz. I don't get this in patients on active surveillance because I find that it opens a can of worms. Very rarely do you find BRCA1, BRCA2, ATM.
Well, 4%.
Dr. Carter's data would be less than that. That doesn't mean if there's not a strong family history or other indications or other family members that have other malignancies, particularly pancreatic cancer, breast cancer, ovarian cancer, I wouldn't go ahead and do it. But if all they have, some guy comes in, he's got low-risk prostate cancer, his PSA is like 4, he's got a 100-gram prostate, and his PSA density is 0.05, it's not worth it.
No, and I think this is a relevant topic, especially as we're approaching our fourth module here, where Dr. Srinivas will talk in a minute about the use of PARP inhibitors. But let's hear from Drs. Morris and Hafron on where are we with selecting the optimal combination of AR and PARPs outside of the mCRPC setting.
Our CME group has tracked the evolution of PARP inhibitors first in the management of ovarian cancer, then breast cancer, then pancreatic cancer, and now prostate cancer. And it seems quite likely that the role of this fascinating treatment strategy is likely to do nothing but expand in the future in prostate cancer. So, bright future ahead, but questions.
With the approvals of the combination of many PARP inhibitors with an AR agent paired with it, what's been your management for patients who've already been pre-treated with an AR agent in the hormone-sensitive setting and are now progressing into castration-resistant? Are you switching the AR backbone and pairing it up with a PARP inhibitor? Are you treating them as a PARP inhibitor monotherapy patient?
PARP inhibitors are great. We've seen 3 great trials with PARP inhibitors with probably the greatest responses we've recorded in advanced disease in the HRR mutated patients. Would you ever consider using a PARP in a metastatic castrate-sensitive prostate cancer based on the success of them in mCRPC? How do you decide which PARP to use? We have one PARP which has 14 mutations that it's approved for. The other 2 are just approved for BRCA1 and BRCA2. How do you explain that difference? Why did one get 14 indications? We know it's probably effective for BRCA1 and BRCA2, but what about the other 12?
Such relevant questions for all of us, especially as this particular field has just exploded in the last year or two. And I'll leave Dr. Srinivas to last since this is her topic. But Dr. Aggarwal, how do you approach the selection of an AR inhibitor to pair with a PARP for a patient who's already been treated with a AR inhibitor in the hormone-sensitive setting, as you just finished telling us?
Yeah, it's a great question. It's a gap in our knowledge. The 3 phase 3 studies largely were in true first-line mCRPC where patients had not had AR inhibitors. Talipro-2 with enzalutamide talazoparib did have about 8% of patients, I think, had prior abiraterone. I would say it depends on the mutation and what the prior therapy was, but for the majority of patients that come into mCRPC having progressed on an AR inhibitor, I tend to use single-agent PARP because we just don't have the data with combination in that setting, and then maybe save this AR inhibitor for a future line of therapy.
Mm-hmm. Dr. Klotz, any role for PARPs in your practice?
This has recently kind of emerged. Canada, I think it's taken a little longer to get funding in particular approved. So I have just begun to use these. The data is conflicting as to whether this is effective only in patients who have an HRR mutation or not. You know, one of the trials showed a benefit in both groups, but I think given the cost, there is significant toxicity associated with these drugs, so I just use it in patients who have a clear-cut HR mutation. And I thought the question about the difference between the different PARP inhibitors is very interesting. My impression is that these are basically Me Too drugs, but I'd be curious to hear what the medical oncologists say.
Well, I know we're probably going to go into that a little bit more, Dr. Srinivas, but just on the broad strokes of all the different 4 PARPs that are been studied, do you feel that they're different from one another?
I do think that they are different. I mean, they are in the same class of being PARP inhibitors, but you can see that the activity is a little different for each of these drugs. Toxicity profile-wise, I think it's hard to separate. They all have a class effect of fatigue and GI side effects. But if you look at the biology, there is some difference in PARP trapping and potency of these drugs. So I do think dosing and the considerations for those do make these drugs a little separate, and they can't all be considered the same.
Well, and Dr. Kibel?
I was going to say, so there's 2 things here that I think are important. I think the mechanism of action is different, and maybe we're going to go through that. But also people don't appreciate, they say PARP inhibitor like they say AR inhibitor. There are multiple different PARPs, and they probably all play a role. in slightly different ways, and they all had different, PARP1 I think is the important one, but PARP2 may have a role as well, and they all have different effects on the different genes. So I think we are going to see some differentiation there between the different drugs.
Absolutely. And I know in our next video, it's really the topic again of toxicities. So just because we have these novel agents, what does this mean in terms of managing their toxicities? What should we be worried about? Does it get compounded because now they're in combination? Let's hear from Doctors Love, Morris, and Hafron.
As alluded to by Dr. Hafron, it'll be interesting to see where PARP inhibitors land in the natural history of prostate cancer, perhaps hormone-sensitive metastatic disease, which may be what we called in the past high-risk biochemical recurrence. But nonetheless, our consultants have many questions about the current use of PARP inhibitors in prostate cancer.
Have you noticed any clinical differences in terms of tolerability between the combinations that are currently available, outside of some being for some gene sets and some being for other gene sets? Are there particular combinations that you discuss with a patient about certain toxicities that are more with one than the other in your experience? So if you have someone facing a grade 3 anemia, first of all, how would you define that? What are you looking for as a trigger in your lab testing or symptoms? And how do you manage it? Are you stopping the drug transfusion? Are you waiting for them to recover? Are you continuing to treat through the transfusion process, or are you just dose reducing from the very beginning?
We've seen some pretty significant anemias that develop right at start. So you have to be watching these patients closely, especially in the first few months, because you can see them show up or lab result come back with a hemoglobin of 7 or 8. So when you see that low hemoglobin of 7 or 8, what do you do with that patient? With the PARPs, we're seeing significant nausea. Any recommendations to minimize that with our patients? Patients on PARPs will develop fatigue, anemia, and nausea. Any suggestions on how to manage any of those 3 adverse events or side effects? I think adverse event management, especially in urology, is going to be critical. When placing a patient on a PARP inhibitor, how do you monitor the patients? How often are you checking CBCs? And are you giving any supplemental anti-nausea medications with these patients?
All excellent questions. And I think from, again, a multidisciplinary approach, this is the co-management with the med-onc, so that you're perhaps managing the AR piece and the med-onc is managing the PARP. But how do you manage typically, Dr. Srinivas, the anemia that occurs with this class of drugs?
So it does seem almost like chemotherapy. I think about PARP similar to chemotherapy. They have marrow suppression, they have GI toxicity. So I treat them like we would have any patient with cytotoxic drugs. You give them the drug, you give them all the information about the side effects. We bring them back in a month to have a repeat CBC done. Most of the time, and they are part of our Beacon plan, when we order these drugs, have supportive therapy, which includes anti-nausea meds that these patients get sent home with. And if there is anemia, typically we don't transfuse, we would hold the drug, and we would then allow their hemoglobin to recover and dose reduce.
Dr. Aggarwal, do you subscribe to the similar type of approach, or do you do something different, especially in managing the fatigue, the nausea, and any other symptoms?
I think our management is similar. I think the key point is that these, especially the anemia, comes on quickly when you start at the standard full dose. So you should need to be checking CBCs frequently. We'll sometimes check even every 2-week labs initially until we lock in on the right dose. Recovery is also quick. So you hold the dose when you start getting into close to grade 3, which is less than 8 with the hemoglobin. Typically recovery is within a week or 2, and then you can restart at a lower dose. And once you get past that initial stage, usually then you can keep the patient at that dose level, and quality of life and toxicity is better.
Dr. Kibel, to Dr. Hafron's earlier question in terms of, is it BRCA1 and 2? Is it BRCA1, 2 ATM? Is it the 14 family members? How do you advise your patients who then did get testing and say, oh, what do I do with this?
Yeah, so I think the BRCA1, BRCA2 story is cut and dried, okay? And the data on, I think it's Talipro, where they show that it's, possibly good in everybody or works in everybody, or into the other extreme. I have a shade of doubt about that. I'm a little concerned. It was not only patients that were negative, but also patients that had, they weren't able to test for a variety of different reasons. And I'm worried that the positive signal is solely in the people that happen to have defects in DNA repair. I think the harder thing is those smaller, rarer mutations. I'd like to be an optimist and say the drugs work, but they're very small numbers of patients. And I don't think the data is nearly as strong. I think the synthetic lethality associated with PARP inhibitors that are predicated on BRCA1 and BRCA2, I'm not convinced that's true for those other DNA repair defects.
Absolutely. And I think as we now hear from Dr. Srinivas, so I'll invite her up to talk about where we are with the use of PARP inhibitors right here. It's really important to keep what Dr. Kibel has just said in mind.
Thank you so much. So let me hit the topic of PARP inhibitors. So as you can see up here, what is the prevalence of these mutations, right? So if you think about between germline and somatic testing, 1 out of 4 patients with metastatic disease is going to harbor one of these mutations. The most common is BRCA2, which is seen in about 44%, but you can see a smattering other genes, including BRCA1, PALB2, ATM, etc. The other point I want to make here is that as you go from localized disease to hormone-sensitive disease, the prevalence definitely increases as you get to CRPC. Now, what the first drug that really got us into the CRPC space that made PARP inhibitors available as a therapeutic option came from this trial, the PROfound study, testing olaparib, the first PARP inhibitor. So this trial took patients with CRPC who harbored one of those genes that I've highlighted up here in red, and they really put them in 2 buckets. They put BRCA1, BRCA2, and ATM in cohort A and all others in cohort B. Within these cohorts, they were randomized to either olaparib or the alternate ARPI. So if patients got ENZA, they were randomized to ABI and vice versa. The endpoint of this trial was RPFS. So here is the primary endpoint was met. You can see that patients who got the PARP inhibitor olaparib had a better hazard ratio and had an improvement in RPFS for cohort A. For the entire cohort, which is in the lower curve, the benefit is less, so it appears that most benefit comes from cohort A. And here is the overall survival. Again, the first column is the overall survival for cohort A. Again, a good hazard ratio supporting the use of olaparib in patients with BRCA1, BRCA2, and ATM. And 66% of patients actually had a crossover, and the curve below shows despite the crossover, survival benefit was still seen. The middle column is cohort B, and it's a negative in this patient population. And the last column sort of is a combined population. Again, the message here is that the benefit appears to be coming from cohort A, which is BRCA1 and BRCA2 population. The approval this was the first PARP inhibitor, and I must say I was surprised too that the drug got an FDA approval not just for cohort A, but for all HRR mutations who had progressed after ABI or ENZA. The second PARP that came on into the market was rucaparib, and it was based on this slightly different design compared to the previous trial, where patients here were just selected for BRCA1, BRCA2, and ATM, and here they were randomized to either rucaparib or physician's choice, and the physician's choice here included the alternate ARPI, as well as docetaxel was given as a choice. Again, endpoint here was RPFS, and the trial was positive in that the patients who harbored these BRCA mutations did do better with rucaparib compared to either docetaxel or the alternate ARPI. You can see the ATM group had 0 benefit here and was negative for that group of patients. And this drug did have FDA approval for a more limited indication for just BRCA population. Then came the concept of combination, and really here the concept is could there be co-inhibition of AR and PARPs? And would that then lead to a broader group of patients, not just those who harbor HRR, but to a broader group of patients? And this came from a small phase 2 study that had showed that irrespective of HRR mutations, there was benefit seen with the combination of olaparib and abiraterone. That led to 3 large trials, and I'm going to start with the first one, which is PROPEL, which looked at patients with first-line CRPC. Now, these are patients who have not had any prior ARPI, and they had this, they were unselected. So really, they didn't bring them on into the trial with any HRR testing. There was testing done, and I'll show you the data that was done later. So these patients were randomized to olaparib plus abi or placebo plus abi, and it was a pretty large trial. And here is what I would like to share. So if you look at the patient characteristics, the patients who were HRR positive was a small number, really at about 27%, I think, and the majority were HRR negative. The trial did meet its primary endpoint of having an improvement in rPFS compared to the placebo group. And if you look at the forest plot, you can again see that the HRR positive patients had a hazard ratio of 0.5 compared to 0.76 for those who are HRR negative. And the overall survival was immature. It was interesting that the FDA did a post hoc analysis and found in this cohort that they were 11% BRCA positive. And in the BRCA positive patient, you can see an impressive hazard ratio of 0.3. But if you're BRCA negative, the hazard ratio actually exceeded 1. So there was a unanimous vote for FDA approval for just limited to the BRCA population in CRPC. Here are the side effects that have been mentioned previously. Again, it's anemia in about half of the patients, fatigue in about 40% of patients, and again, nausea and GI side effects are the contribution of PARP to this combination. Moving on to the second combination, which is Magnitude trial using another PARP, which is niraparib, but in combination with abi. Here, the trial upfront started off with 2 different cohorts, those who are biomarker negative and those who are biomarker positive, slightly different panel of genes. And the HRR negative cohort was completely negative and was closed for futility. The HRR positive cohort, again, it's a very similar theme. To the left are patients who are HRR positive, and the trial was positive. The hazard ratio was 0.7, but the magnitude of benefit was much higher in the BRCA population with a hazard ratio of 0.5. The third trial is the TALAPRO-2, which sort of combines the first 2 trials in a way where they had both all comers, plus they had a cohort who were just HRR positive, but you have a different PARP, which is talazoparib, and a different ARPI, which is enzalutamide here. And again, their panel of genes are slightly different as well. This trial did have an improvement in rPFS in the intent to treat, which is in the left side. So these are including all comers. And you can see again, the group that was HRR positive had a much higher benefit with a hazard ratio of 0.4. TALAPRO-2, again, there is a dose interruption you can see happens in about 75% of patients with the combination, and about 60% require dose reduction. It's similar having anemia and GI side effects. So here I've summarized all 3 trials for you. Their genes are not all the same, number 1. And the message I want to highlight here is that the BRCA group has the highest benefit. You can see hazard ratios at 0.2 for both the PROPEL as well as the TALAPRO-2. The next group who benefits are the HRRM positive, and the non-HRRM have much less benefit. None of these trials have an overall survival. I want to briefly mention this trial called the BRCA Way, which is a much smaller trial that just took patients with monotherapy, Abi, olaparib, or a combination, and at progression, they were allowed crossover. And this again brings out the concept that you can see in the combination much superior PFS, almost tripled compared to the monotherapy. Objective response rates are higher. So there is a concept of combining these, especially in the BRCA population. NCCN guidelines have these where for category 1, if you have never had any prior exposure, and have a less level of evidence for the other groups. So I just wanted to mention one thing about patients who have had prior ARPI. What is the role of these combinations? You can see up here that they have had very few patients, less than 1%, 3% in magnitude, and 8% in TALAPRO-2. So really, we are in a data-free zone for this. We know that there's no overall survival. And I would say in practice, we know that there's significant cross-resistance with the alternate NHT. So you can see some of the contemporary trials looking at the control arm, again showing very similar data. So these are the ongoing trials looking at PARP inhibitors in the hormone-sensitive space. So we'll certainly await those trials. So I'll conclude saying that monotherapy PARP is active in BRCA mutations. Combination, again, is active in patients with BRCA. There's no level 1 evidence to use combinations in patients who have had prior NHT. The benefit in non-BRCA is less, and I really think that the benefit in non-HRR does not justify the cost or toxicity. I think I'll wrap with that.
Great. Thank you so much. Lots of data that's just been shared. Again, we don't know patients who are eligible if you don't test. So I think we'll keep messaging that. Please make sure when appropriate to test so that you know if PARPs are part of the story for your patient. I'm going to ask Dr. Srinivas a tough question, which is what do we do with ATM? It's been topic of multiple discussions. When it's BRCA 1 and 2, we seem to have better marching orders, but ATM is a tricky one and keeps getting thrown under the bus. Thoughts on ATM?
Yeah, I think within these various genes, there is different levels of sensitivity. And to me, I think when we have other life-prolonging drugs, I'm not sure I'm going to put a patient on a PARP combination when I could be offering them other life-prolonging drugs. I think when we didn't have any and you had a patient with ATM, sure, it was very tempting to offer monotherapy, olaparib, or, yeah.
Absolutely. Yes, Dr. Klotz.
Could I just ask Dr. Srinivas, can you elaborate on the somatic testing that you do? Because I think for urologists, it's a real conundrum. Let's say you have a patient who had his radical prostatectomy 15 years ago, and he's progressed, biochemical failure. Now he's got metastatic CRPC. How do you sort out whether he's got somatic HR, and let's say germline negative?
Yeah, I mean, I think we look to do a biopsy, a fresh biopsy, especially for these patients who have had their radical prostatectomy decades ago. So if they have a visceral disease, nodal met, even bone mets biopsy is coming along, though it is a little challenging. But if we absolutely have no tissue to test, we will resort to liquid testing with one of our ctDNAs.
Absolutely. Dr. Kibel?
Can I ask you, and this is sort of a more broad question, but it came up to me while we were discussing PARP inhibition. BRCA mutations are much less common in different ethnic groups, particularly African Americans, that are incredibly high risk for, as we all know, for aggressive and lethal prostate cancer. And I believe there's good data out there that they respond better to androgen deprivation, novel androgen deprivation. So I'm just curious if either of the medical oncologists want to comment on whether ethnic background impacts on their decision to proceed with one avenue or another.
Dr. Srinivas?
I mean, I don't know if we know with that level of granularity between, I think race study is becoming more prevalent now. We have much more information on things like Sipalucil T, abiraterone. I don't know if we have that level of granularity with PARPs, and I think that brings to the point of enrolling African American men in clinical trials so that we can have that level of data.
Absolutely. And I think with genomics, it's also underrepresentation on every level. So that's also really important.
We also want to expand maybe the definition of what is a DNA defect in that ethnic group. So we did some studies looking at patients with metastatic disease and found the percentage of patients that had DNA repair defects was the same. But unfortunately, they weren't in BRCA1 and BRCA2. They're more evenly distributed across the genome.
Yep,
It's just tricky.
It's an unmet and under-researched area as well. I'm going to move on to the last module here for all of us, so thank you for sticking with us. We're going to be exploring with Dr. Morris and Love the definition of PSMA positivity and the role of alpha-emitting therapy in the era of PSMA radioligands.
Radioligand therapy of prostate cancer is a classic example of translational advances benefiting patients. While radium-223 created a great deal of interest in this modality, it was lutetium-177 that has profoundly affected the systemic treatment algorithm.
Are there specific markers from the PSMA in terms of SUVs compared to the liver, compared to the arch of the aorta, compared to the blood pool? What is your count to consider something active? And do you think it's important to look at that active number to predict to a patient if they're going to respond to radioligand therapy? In an era where we have radioligand with a biomarker of PSMA positivity, is there still a place for an alpha-emitting therapy like radium for patients who may not be PSMA positive, or for those that have bone predominant disease and tend to have bony symptoms, or in the greater sense are pre-chemotherapy, which has an option of getting radium but may not be able to get lutetium approved? So where do you see radium fitting in with radioligand therapy with PSMA on the availability?
That's a terrific question. And Dr. Aggarwal, are you sending your patients for a consult for radium?
Yeah, I mean, I think that for the radium versus lutetium question, it's a tough one because, we don't have any head-to-head data. I would say at our center, in the post-taxane setting, we're predominantly prioritizing lutetium if there's sufficient uptake on PET, and our radiologists will look at both the vision and the therapy criteria and really score the degree of PET positivity. It's clearly not a binary yes, no, but really a spectrum in terms of the range of uptake, and that does impact our decision making. We will selectively use radium-223 post-lutetium for patients that have bone met predominant disease, and the nice thing is you can get a PSMA PET that really, with a high degree of sensitivity, rules out soft tissue metastases and allows us to select those patients.
Now, how do you define, Dr. Kibel, the positivity on a PSMA PET? I think we all agree in this room that the reading is perhaps not as consistent as one would hope, depending on where you practice and what institutions you're at. Thoughts there?
Yeah, I mean, I think it's just an amazing question. I was thinking, I haven't spent a lot of time thinking about that, actually. And so I think my take-home message is I'm going to go home and talk to people about it. I think it's a breakthrough treatment. I think we're going to need to be able to tailor the treatment. I often think in terms of imaging that's negative, like the patient has a positive PSMA PET and has other lesions that are not positive, and that's not a good patient for lutetium. But I haven't really thought a lot about the SUV and how that's going to impact on whether the patient's going to be respond. I'd be very curious what the other panel members thought about that.
Yeah, I mean, Dr. Klotz, how about you?
Yeah, so I would say we restrict this to the patients who are clearly positive, and which is actually the majority. So the borderline patient, I would, insofar as this is a therapy that requires PSMA expression of the metastasis to be effective, I don't see why you would give it if there's really a question about whether the patient's disease is PSMA expressing.
Absolutely, and I think we'll learn, briefly touch on the VISIONS trial, sort of what those qualifications are. Let's hear again from our Dr. Morris and Dr. Love on how do we actually integrate a lot of the results from PET imaging into whether it's surveillance or actual treatment decisions, especially as relates in the pre-taxane setting.
A few more questions on radioligand treatment of prostate cancer, and we could keep this going for a long time.
We know that PSMA scans are far superior to CT and bone scan. How do you use PSMA PET scans when you're surveilling patients with metastatic castrate-resistant or even castrate-sensitive prostate cancer with a stable PSA? In order to use lutetium based on current approvals, that patient has to have seen docetaxel. So I think the question is that we're seeing mixed responses in some of the recent lutetium interim analysis. So we're seeing improvement in progression-free survival, but the overall survival is not showing impact. Can someone comment on why we're seeing this? Because we all know that these agents are excellent, but is this a trial design issue or is this a biology issue that these agents are truly better after chemotherapy?
The struggle of sequencing and when you insert things as we keep discovering more novel agents, how do our patients really benefit from a lot of this data for clinical practice? So we'll start with something practical. Dr. Srinivas, are you using PSMA PET scans for surveilling patients either in CRPC or hormone sensitive?
We have a lot of availability of PSMA PET imaging, so I think it'll really come down to access as to who has that. We are also fortunate that we have a lot of experimental PET tracers, so we have an opportunity for our patients to get these. But outside of that, I definitely do it more in the CRPC setting to assess whether the patient is a candidate for lutetium-177. And we made a recommendation in the NCCN that even for patients who have stable PSA, they should get some sort of imaging, whether it's, and I think we left it broad, that if you have access to PSMA PET, you could do that. But I think periodically some imaging, whether it's conventional CT and bone imaging, is recommended.
No, thank you for that. And I think just want to acknowledge one of the questions from this audience is, again, access as well as initial staging versus monitoring, as many centers around the United States don't have equal access to this PSMA PET scan. So it's duly noted, and I think something that all of us really understand. Dr. Aggarwal?
Yeah, I mean, I think that, one of the important caveats is we don't really know what defines response or progression by using PSMA PET in the mCRPC setting. And I think one of the dangers is you kind of revert back to using almost like PSA values to change therapy. You're going to see new lesions, and lesions get brighter on a PET earlier than changes on CT and bone scans. So there's a risk of prematurely switching systemic therapies. That being said, it's increasingly used in the setting, and we do have it integrated in phase 3 trials. That'll hopefully give us data, at least from a clinical design standpoint. How do we define RPFS based on PSMA PET? The other point I just want to make, that important caveat as well, is that the PSMA PET, if it's a non-diagnostic CT that comes along with it without contrast, you will sometimes miss things like occult liver metastases that are PSMA PET negative. So it's one of the things in the mCRPC setting, making sure you're still getting a good diagnostic CT is important.
Your perspective then on sort of where we are with lutetium-177 pre-taxane?
Yeah, we'll see more data coming up. There was a press release that, with longer follow-up, the pre-taxane, the PSMA-4 study is showing a better hazard ratio for overall survival. At the first interim analysis, it was 1.16 or so. I think it's going to be less than 1. That was probably just a byproduct of more events and longer follow-up. There was a lot of crossover in that study. That being said, I think there is still this biologic question about persistent bone marrow toxicity and whether that limits subsequent therapies and whether that impacts long-term survival. I think is an open question.
Yeah, no, absolutely. And maybe then we'll move on to sort of my section, which is other novel therapies for patients with metastatic prostate cancer. Again, this is a look forward to see what is actually out there. We just briefly mentioned about the role of radium-223. As a reminder, it is still an FDA-approved agent, radioactive alpha emitter, specifically going to the bone metastases. And in this case, it's indicated for men with symptomatic bone-only metastatic prostate cancer, with a caveat that if you do have lymph nodes up to 3 centimeters, you're still eligible. And the definition, again, of symptomatic is patients who are taking any type of pain medication, perhaps for bone pain. In this instance, it was really based on the Alsimca trial. Again, a reminder for those of us in the audience that this phase 2 study was really quite important in establishing the role of radium-223. Here, you needed to have greater than 2 bone metastases, no known visceral metastases, and again, post-docetaxel, or at least unfit for docetaxel. And here people were administered radium-223 with best supportive care versus a placebo saline with best supportive care. And in this instance, you see the survival curves here of having a hazard ratio of 0.7 compared to placebo. So really, I think important, especially in the early days prior to all of these novel agents that we just heard about, especially with PARPs. Now, there was an update on the long-term safety several years ago on topics we worry about, I think, as whether you're urology, radiation oncology, or medical oncology, which is ongoing myelosuppression. So here, that incidence is low, and more importantly, long-term follow-up show no AML, no MDS, or concerns where you could have a secondary cancer. There was one patient with aplastic anemia after 16 months post of their last injection. So important to know that that agent is still there. Where are we in terms of utilization of this compound? Looking at REASSURE, which is a global perspective observational study of radium, looking at 1,400 plus patients. These patients were 12% of them at least treated with subsequent taxanes, and you could see that 7% of the drug-related grade 3 adverse events received taxane post-radium really was quite small. So taxane therapy post-radium is tolerable, but there's still so much more that we can learn, I think, from this agent. Combining it with the ongoing phase 3 DORA study will really show a lot more information, as well as the lessons learned from ERA-223, which was combining radium-223 plus ABI. And in this case, the combination did not improve the symptomatic skeletal event-free survival, and unfortunately was associated with increased frequency of bone fractures. So really important that sometimes we worry about combinations not being effective, but you can also cause harm, and so that's something we're very mindful of. In the PEACE 3 study, where it's radium-223 plus enzalutamide, there was an addition of a bone protective agent that reduced that risk of fracture. We see other agents here in combination that are in ongoing trials. So again, interestingly, plus an immunotherapy, plus lutetium-177, and plus niraparib. So we'll see how that pans out as time goes on. Many of us in the room are quite familiar with the VISION trial. I think this was a game changer of sorts and really opened the door for radioligand therapy. And as many of you are following that, I think the targets and the agents that are being developed now are ongoing with multiple different trials being formulated. In the VISION trial, it was for patients who have had at least one novel hormonal therapy, as well as 1 or 2 taxane regimens. And in this case, that 2-to-1 randomization of lutetium-177 versus whatever was your standard of care with routine follow-ups using conventional scans, again, so not PSMA PET, resulted in a positive overall survival. Here we have a hazard ratio quite significant at 0.62. The curves stay apart, and I think this has now really been implemented and integrated into our routine clinical practice. As such, the drug did delay time to worsening and health-related quality of life and time to skeletal-related events compared to standard of care. And more recently, there was an evaluation of, do you give all 6? Do you keep going until the end, which is, again, 6 treatments are indicated. Here, a longer exposure of lutetium-177 plus standard of care was actually not associated with a higher toxicity risk, so no special safety concerns with cycle 5 and 6. We mentioned briefly about the PSMA-4 trial, and I think many of us are quite anxious about getting these results. These are for folks who have had one novel hormonal therapy, and you could see in the one-to-one trial design, you're either treated with lutetium-177 or the other novel hormonal therapy. There is some crossover allowed upon radiographic progression, so that's something to keep in mind. This is where the status is, where there are 584 patients screened, those that have gotten the PET scan. This is the randomization, and these are the discontinuation rates, and then those who then crossed over to then receive lutetium-177. So early data here showing that the median rPFS was at 12 months with lutetium and 5.59 months with the novel hormonal therapy. Obviously, these are, again, just rPFS, and we're looking for the OS. And as Dr. Aggarwal alluded to, we will need to wait until we see where that really pans out. But I think anxiously, this could also then reset the sequencing of how we think about what to give our patients next, and where do PARPs play into that. We're going to have to really have another event like this to duke it out to see who will come up on top. Again, the field of radioligand therapy is really exploding. Many of you are aware of another treatment using another compound, still lutetium-177, PNT2002, known as the SPLASH trial. This was a large phase 3 study as well. And that was lutetium versus the other novel hormonal therapy. And what we know so far is sort of what's been a press release last year from December of 2023, showing that there was some positive data with their rPFS of 9.5 months versus 6 months. So the OS survival data still remains immature. We will need to wait to see what happens, but like in anything else in oncology, many more of these types of agents will be coming to fruition, and we will need to keep an eye on what's happening here. The safety profile remains reasonable, and it's something to think about. As we think about what else, CONTACT-2 was recently reported as well. This is leveraging this knowledge that prostate cancer is associated with an immune suppressive tumor microenvironment, and that our world of immunotherapy with this is sometimes not as straightforward. We've also had a robust experience, especially in uro-oncology, with the world of cabozantinib, and as such, this has led to several studies, COMET-1 and COSMIC-021, of evaluating cabozantinib as well as cabozantinib and atezolizumab. And recently, the CONTACT-2 data was reported showing, again, cabo plus atezo versus a novel hormone therapy. Again, an interesting idea. And the top-line result from August showing that it was meeting one of its two primary endpoints. So OS, again, is not there yet, and it will be continuing. But here, looking at the results reported from Dr. Aggarwal from this year's ASCO 2024, again showing the results of PFS in the IIT population, showing a median survival of 6.3 versus 4.2 months, and then the interim OS analysis showing a 16.7 months versus 14.6 months. So that, I think, had a lot of robust discussion, as one might allude to, and I think responses for that is still quite mixed. So that is an ongoing topic for future digestion. But just other things to keep in mind, I think the world of CAR T cells are still in clinical trials and appropriate for the right patient. Bromodomain inhibitors, androgen receptor degraders, known as PROTACs, a lot of other agents such as bicyclics or other drug conjugates. And my reminder for all of us to consider clinical trial enrollment, when I just looked at clinicaltrials.gov, there are 904 interventional and open and accruing clinical trials for our patients with prostate cancer. So I will stop there and maybe ask one or two questions just to get people's take on here. Dr. Aggarwal, thoughts on CONTACT-2?
Yeah, as you said, a lot of robust discussion. High-risk group, these were measurable disease, so high visceral metastasis group, yet a weak comparator with an ARPI switch and a modest PFS hazard ratio. I think all kind of dampened the enthusiasm. That being said, I do think there's a role to explore other immunotherapy combinations in prostate cancer for sure.
Absolutely. And Dr. Kibel, I'll give you the last word. Thoughts on how you would incorporate lutetium-177 should the PSMA4 turn positive?
I mean, if it's positive, then we'll start moving it earlier and we'll use it more and more. I mean, I think it's fairly well tolerated. I think I worry a little bit, as we all do. I mean, we've been moving more and more to combination agents, and I think we're a little unsure how lutetium is ever going to be used as a combination. And certainly the combination of the radium-223 with, I think, abiraterone showed adverse outcome, not a positive outcome. So I think as we move forward and we moved treatments earlier, we have the advantage there. Patients are healthier and are going to be able to tolerate it better, but we need to temper that with a little bit of concern about drugs interactions. And radioligands are very different from systemic therapy, and we'll have to sort of evaluate as we move forward.
Thank you so much. And I want to thank everyone in the audience, as well as those attending virtually, for spending some time with us to learn about prostate cancer, and to my esteemed panel here for all of their insights. Thank you so much.